Hi everyone, my name is Marianne Sanchez and I'm going to explain levothyroxine. Starting with an overview of the drug, the generic name is levothyroxine sodium and it's sold under several brand names including Synthroid, Euthyrox, Levoxil, and Unithroid. Levothyroxine belongs to the systemic thyroid hormone class, meaning it's lab made. It's a synthetic form of thyroxine, also known as T4. Pharmacologically speaking, levothyroxine's function is to replace the body's natural thyroid hormone, T4, because the body may not be producing enough of its own due to hypothyroidism. Once administered, it's converted in the body to T3, the active form, which is vital for the body in regulating metabolism, energy production, and growth. Let's take a look at the pharmacokinetics of levothyroxine. Levothyroxine has an oral absorption rate of about 60 to 80%. And it's best absorbed on an empty stomach, ideally 30 to 60 minutes before breakfast, due to certain foods interfering with absorption, such as calcium and iron-rich foods. Once taken, the onset of action is quite slow. It takes around 3 to 5 days, since it mimics a natural hormone that works slowly. The peak serum concentration typically takes about 2 to 4 hours after dosing, but the therapeutic effects are delayed due to its gradual metabolism. It has a long half-life of about 7 days and is why dosing is usually once daily, and it takes several weeks to see the full effect of a dose change. Levothyroxine is primarily excreted through the kidneys, so renal function can influence how long the drug stays in the system. Monitoring renal functions may be beneficial in certain patients depending on their comorbidities. Due to its long duration and slow onset, it is very crucial to teach patients the importance of adherence to treatment and consistent dosing when adjusting therapy. Next, the dosing and administration of levothyroxine. The initial dose for most healthy adults is typically around 1.6 micrograms per kilo per day. However, the elderly and patients with cardiac conditions may start at a much lower dose of about 20 to 50 micrograms per kilo per day. Therefore, we reduce the risk of cardiac stress. Dose adjustments are made based on TSH levels, which are monitored and rechecked every 6 to 8 weeks through blood work after starting or changing the dose. The TSH is the primary lab marker used for thyroid hormone balance, since it takes time for levels to stabilize. Concerning the route of administration, levothyroxine is available in various presentations, from tablets to liquids to soft gels to intravenous. All of these are helpful for patients with absorption issues in the stomach or swallowing difficulties. Now, when talking about indications for levothyroxine sodium, it is first line for primary hypothyroidism, which is the inability of the thyroid gland to produce enough thyroid hormone on its own. However, it is also used for TSH suppression in patients with history of thyroid cancer, reducing the risk of cancer relapse by lowering TSH levels. Additionally, it can also be prescribed for secondary and tertiary hypothyroidism, which is caused by dysfunction coming from the pituitary or hypothalamic gland and not from the thyroid gland itself. Adverse effects and contraindications. When talking about levothyroxine, common adverse effects include symptoms such as anxiety, insomnia, palpitations, and tachycardia. In extreme cases, when the dose is too high and the exposure has been excessive, it can cause unintentional weight loss and menstrual irregularities, such as menorrhea, oligomenorrhea. Otherwise, it is well tolerated when patients experience side effects. The dose may be too high, or the adjustment has been too abrupt, like decreased too abruptly. Relevant contraindications to be aware of when using levothyroxine are: one of them is should not be used in patients with untreated adrenal insufficiency, since it can provoke adrenal crisis, nor with patients in acute myocardial infarction due to the increased cardiac demand triggered by it. Even if they were already taking it, it will be held and reintroduced gradually. Additionally, patients demonstrating hypersensitivity to levothyroxine or any component of the formulation as well. Clinical considerations. Going over clinical considerations when managing patients on levothyroxine, there are several clinical considerations to keep in mind. First, TSH levels should be monitored every 6 to 8 weeks after starting the medication or when readjusting the dose. The time frame allows for evaluation of how well the patient is responding and to make sure thyroid levels are within the target range to reduce adverse effects. Moreover, with patients in lifelong therapy, as is with primary hypothyroidism, consistency is vital, and the dosing and monitoring are essentials for long-term health and symptom control. Additionally, some patient populations require special considerations, such as pregnant patients. Levothyroxine is classified as a category A, so it's considered safe for use and is often required to be maintained during pregnancy for normal thyroid function. They require closer and more frequent monitoring, and often dose adjustments are due to increased metabolic demands. Since proper thyroid hormone levels are essential for both the mother and the fetal development, so treatment should not be interrupted. Also, elderly patients and those with cardiovascular disease may need lower doses to reduce the risk of cardiac strain, as I mentioned before. Cost analysis. In terms of cost effectiveness, levothyroxine is generally affordable. Different options have different pricing. The generic version, which is the most affordable, ranges between $4 to $10 for a 30-day supply, in comparison to the other brand names options like Synthroid, which is the second most used and known, and it costs $20 to $40 for a 30-day supply. Inevitably, the cost will also change between individuals for the same drug depending on the pharmacy and insurance company coverage. However, levothyroxine has shown results to be practical long-term treatment for most patients for hypothyroidism. The following case study for management of hypothyroidism with levothyroxine. We have a patient FO, a 52-year-old female high school teacher that comes to the clinic with a chief complaint of weight gain, fatigue, despite sleeping 7 to 8 hours every night. Per medical history, this includes reporting progressive fatigue and progressive weight gain, constipation, and increased sensitivity to cold temperature over the past 3 months. She denies changes in appetite, hair loss, or depression, but feels foggy mentally. Her family history reveals her mother and older sister both have thyroid issues. During the physical exam, findings such as blood pressure of 118/74 and a heart rate of 58 beats per minute, cool and dry skin, delayed ankle reflex relaxation, and a non-palpable thyroid leads us to assume she could be suffering from thyroid issues as well, just like her family. Diagnosing her will require to order labs and maybe imaging. So the nurse practitioner can order labs to check on her TSH level, T4, and anti-TPO antibodies to properly diagnose. The results come back with the following values: TSH of 11.2, free T4 of 0.6, and anti-TPO antibodies, which are positive, which indicate primary hypothyroidism, likely autoimmune thyroiditis. The treatment plan would be to help this patient manage her new diagnoses by starting a moderate dose of levothyroxine, which is 50 micrograms orally daily. Instructions for her to teach her during this new diagnosis would be to take this medication every day before breakfast, 30 to 60 minutes before, and 4 hours before taking any calcium or iron or soy supplements or food that includes these. The follow-up with her would be to check her TSH level, her free T4, in about 6 to 8 weeks to evaluate the response and readjust if necessary. It is very important to discuss with her the long-term nature of the therapy and the importance of medication compliance. This plan is backed up by evidence-based support. Chaker showed the importance of even individualized levothyroxine dosing in newly diagnosed hypothyroid patients. The main focus is to avoid overdosing or underdosing. So the study found that starting a patient on doses of about 25 to 50 micrograms is more therapeutic, especially in middle-aged adults who have no comorbidities or cardiac risks. Next would be patient education. As I have mentioned before, the administration of this medication is the most important part of the education portion. So going deeper into the aspects about nurse practitioner's role in patient education would be to uphold the responsibility of knowing that these patients understand what it means to starting this medication. It is important to emphasize compliance with consistency. First and foremost, the medication has to be taken every day at the same time on an empty stomach between 30 to an hour before breakfast. Second, most important, to avoid taking any substances containing calcium, iron, or soy within 4 hours, since these decrease absorption and interfere with levothyroxine. Ultimately, educate on adverse effects that may indicate overdose, like palpitations, anxiety, trouble sleeping, or temperature sensitivity, so they can report it back to us and we can readjust promptly. Now, talking more deeply about the nurse practitioner's role when managing patients with levothyroxine. They must order and review lab results. They have the responsibility to schedule and follow up through with the patients, educate them, and reinforce education all throughout the process until they adhere to this routine. Especially for TSH levels, using the data and patient symptoms is the most reliable way to monitor treatment and prescribe appropriately for each individual. Another important aspect is when choosing the right formulation. Since every patient is different, some patients may benefit more from liquid or soft gel forms when they have absorption issues, or take medication that may interfere negatively with levothyroxine sodium. Additionally, educating patients on making sure they understand the implications of treatment and compliance to it. Monitoring and follow-up. As nurse practitioners, we must monitor and maintain a follow-up schedule when starting patients on levothyroxine. So as I said before, every 6 to 8 weeks. It is important to take labs, read the results, and adjust appropriately. Otherwise, reinforcing education and assessing where the patients might be missing information or where they could be interfering with their treatment. We must assess not only lab values but also the patient's symptoms. It's very important. They might normalize things that are nothing other than side effects, and this would reduce the risk of overdosing or underdosing. These may be overlooked by the patient, and it can affect their energy levels, weight, heart rate, temperature sensitivity, and mood. Another responsibility is therapy adjustment that may not only look like going up or down dosing amounts, but also formulation. If the patient experiences persistent symptoms despite labs coming back normal, APRNs will need to consider changing the formulation, for example, to a liquid or a soft gel. Lastly, my references. I used 7 references, including 2 for the evidence-based practice portion on the case study. Thank you so much.